Hello, everyone. Welcome to the day 3 of the conference on Delivering for Nutrition in India, Insights from Implementation Research. My name is Rebecca Laishram and I'm from IFPRI. The plenary session on supporting adequate child growth in times of crisis, Why Does It Matter, will be chaired by Rashmi Abula. Rashmi is a research fellow in the Poverty, Health and Nutrition Division at the International Food Policy Research Institute. Her research focuses on understanding processes and determinants that influence program implementation and their impact on nutrition. Thank you all for taking part in the conference, and we look forward to an engaging and interactive session today. Before the chair takes the conversation forward, I have a few technical announcements to ensure our experience is as smooth and interactive as possible. This session will be recorded and posted on the IFPRI-POSHAN website. You can find all information about the conference and other useful resources on the poshan.ifpri.info. All participants have been muted, but later in the session, we will open the conversation. If you have questions, we invite you to share them in the Q&A box throughout the session, and we will do our best to raise them during the Q&A session. If there is time, we may have participants to raise their virtual hands so that we can call on you to speak your question aloud. In case a question similar to yours is already there in the Q&A box, please upvote it to avoid repetition. If at any point you experience technical issues, please check your audio settings and your internet connection. You can always try to reconnect to the session using the same Zoom link and passcode. If you're on Twitter, please use the hashtag #DeliverForNutrition. Thank you, and over to you, Rashmi.
Thank you, Rebecca. Greetings to all the participants, and I'm pleased to invite you on behalf of 19 co-host organizations who have brought together this conference on implementation research in nutrition, Delivering for Nutrition in India. Today is the day 4 of the conference, and this is the plenary session on supporting adequate child growth in times of crisis. Why does it matter? In the morning, we have heard speakers on the topic of severe wasting in India. We now continue our discussion on child growth, but within the context of the current crisis of COVID-19 pandemic. We have 4 esteemed colleagues with us today to share their thoughts on this topic, and I have the privilege of introducing them to you. We'll begin with pre-recorded presentations from 3 of our speakers, and then open the floor for remarks from our 4th speaker. So and the audience can continue to interact with us through posting their questions in the Q&A box. And all the panelists are here with us currently, and they will be answering the questions live. So without further ado, I would like to introduce our first speaker, Dr. Ruel, who is the director of the Poverty, Health and Nutrition Division at the International Food Policy Research Institute. Dr. Ruel has worked for more than 30 years on policies and programs to alleviate poverty, food insecurity, and malnutrition in low and middle income countries. She has published extensively on topics related to maternal and child nutrition, infant and young child feeding practices, and related indicators, urban food security and nutrition, and on the linkages between agriculture, food systems, nutrition, and health. Dr. Ruel received the American Society for Nutrition Kellogg's Prize for Lifetime Achievement in Nutrition in 2019. Dr. Ruel will speak about the estimated impacts of COVID-19 on child wasting and mortality. Could we have the video, please?
Hi, everyone. My name is Marie Ruel. I'm director of the Poverty, Health and Nutrition Division at IFPRI. And I'm really pleased to be here with you today at the conference on Delivering for Nutrition in India. I've been asked to talk about the impacts of COVID-19 on child wasting and mortality. Some of the work I'll be presenting today draws from work that we have been doing with the Standing Together for Nutrition Consortium that had the major aim of working together to connect and build evidence for nutrition action in the context of COVID-19. So it's a group of researchers and development practitioners who decided to come together to make sure that we would have a unified way of approaching nutrition during COVID and make all the efforts possible to protect nutrition in these difficult times. So COVID is affecting nutrition and will continue to affect nutrition through its impacts on all key systems that we rely on for improving nutrition. We know that nutrition relies, for example, a lot on the health sector for the delivery of many of our essential nutrition services. We are also dependent on social protection systems, which help reduce poverty and food insecurity. And we're relying on food systems for making available, accessible, and affordable diets, nutritious diets and nutritious foods for us. And we also know that water and sanitation and hygiene systems are very important to protect nutrition through protecting from infections. So we need these sectors and others to help us protect nutrition, and unfortunately the current crisis is affecting all of those systems at the same time. So in terms of the economic crisis, we all know that we're in a deep economic crisis currently, and we also have severe food system disruptions depending on that vary across countries. But overall, our team at IFPRI predicted that in 2020, we could expect an economic downturn of a reduction in 5%, which would lead to an additional 148 million poor and an increase of 20% in the number of poor around the world. In terms of South Asia, we expect an increase of 15% in poverty. Now, at the same time, the modeling that has been done at IFPRI by David Laborde and others shows that we expect also reductions in consumption of nutrient-rich foods. These include fruit and vegetables and all of the animal source food, meat and dairy, for example. We can see the red bars here that are expected or predicted reductions in consumption of these foods. And we can see that we expect an increase in consumption of staple foods. This is largely because staple foods are not varying so much in price, but also because people are trying to get their energy before they try to diversify their diet. So the more expensive foods are the foods that people will not consume as much of at the expense and will instead focus on getting their calories from staple foods and mainly cereals. And we see that globally. There's also some level of scare. There has been certainly in Africa scares that animal source food were responsible for transmission of the virus, or that fresh food and vegetable were not safe because they were consumed raw. So we have a very complex change in demand and in supply, which in the end means that the populations, especially the poor, are reducing their consumption of nutrient-rich foods and therefore have poorer diets overall. We have all seen these headlines across Latin America, Africa, and India, where people are very concerned, especially the poor in low and middle income country, really believe that they will die of hunger as a result of the economic crisis before they die of COVID-19. So there is a very dire need for addressing food security across the globe right now because of the concerns due to losses in income, livelihoods, and food security. Now, if we focus on what would be the impacts of the crisis on nutrition outcomes, we start with the health system. So we know there are severe disruptions in health systems. There's a reallocation of resources and of health staff to the COVID needs. And this means that there's a reduction in the availability of health staff that can deliver essential routine health and nutrition services. These include, for example, antenatal care, care of the young child during the first 2 years, infant and young child feeding, behavior change communication, vitamin A supplementation, as well as reductions in coverage of immunization as well. There are reductions in equipment and supplies, and among others, there are documented reductions or stockouts on micronutrient supplements, vitamin A supplements, among others, but also antenatal supplements, as well as on products, fortified products like ready-to-use therapeutic foods for treating severe acute malnutrition. And so we definitely expect and see a reduction in the coverage of health and nutrition interventions. The other side of is not just the supply, the other side is also that there has been a reduction in demand for some services, especially during lockdowns. People can't necessarily access or go to the health systems, or they may just be scared of contamination and just decide to stay at home, or don't have and can't afford the expense of transport to the health services. So overall, there is definitely a decrease in the delivery of services, the supply side, as well as the demand side, which results in overall reduction in coverage of health and nutrition interventions. So that's kind of what we expect from health systems. And when we think of trying to model what this impact will look like what this impact will be on outcomes in nutrition, like, for example, on the changes in wasting, we expect that as the coverage of health and nutrition interventions go down, we will have an increase in different forms of malnutrition, and the first one being wasting, which usually responds rapidly to an emergency situation. Infections may go up as well, of course, and we expect that those will lead to increased child mortality. So we use the LIST model, which is the LiveSave tool that has been designed by the Johns Hopkins University and has been used mostly to work with countries in terms of helping them understand how they could reduce child mortality, for example, if they increase coverage of specific health and nutrition interventions. So it's been used really to promote focusing on improving nutrition interventions and the coverage of nutrition interventions in order to reduce different forms of malnutrition as well as reducing child mortality. But in this case, of course, this is the reverse. We're looking at how reductions in coverage that we expect will result in more wasting and more infections and more child mortality. So what's missing from this model? This is a good model for modeling the health impact, the health system impacts of the crisis, but it does not incorporate what we expect to see also in terms of changes in malnutrition and mortality due to the economic crisis. So what we did was to work with other modelers and try to incorporate in the LIST model an indicator that would capture the effects of economic and food system crisis, the losses in jobs, in income, in the reductions in food security and diet quality, the changes in social protection programs, and possibly the reduction in coverage, as well as some changes in food prices, fluctuations for sure in food prices. So we chose the indicator, the gross national income per capita, which is determined, or which is calculated from our IFPRI modeling team led by David Laborde using the Miragro-Dep modeling. So this indicator for us is the indicator that captures beyond the health effects what is happening with the current crisis. We also then analyzed some 177 DHS data sets to look at the association between changes in GNI per capita at the country level and increases or changes in wasting. So we have in the DHS data an ability to see what happens with different levels of economic crisis using previous crisis or shocking the system, if you want, and see the impacts on wasting. So we've included this linkage so that it's not just the reduction in coverage of health and nutrition interventions that will impact wasting, but the economic crisis will as well. So we model both the impacts due to the health systems and the impact due to the economic crisis. And finally, we put these factors in the model, and we use the list model to derive the impacts on child mortality. So what are the results? We find that child wasting, moderate or severe, and we know that child wasting is associated with high levels of mortality, much higher levels than milder forms of wasting. So child wasting is expected to increase by 14.3% in 2020, and that corresponds to an increase of 6.77 million children that will be new cases of wasting. And this is compared to projections without COVID-19. So an additional number of 6.7 million children will have wasting in 2020, according to these predictions, and 80% of these children live in Africa and Asia. In terms of child mortality, what we expect is 128,605 additional deaths in 2020, and that corresponds to an additional 10,000 more deaths per month. So those numbers are very high and very concerning. Now, what are the implications of these findings for South Asia? Well, we know that South Asia is home to more than half of all wasted children before the pandemic. So we have 25.2 million children in South Asia that are wasted over a total of 47%. So this is really a very large proportion that live in South Asia. And in India itself, it's 1 of 5 children under 5 years of age is wasted. We have 12.2% of children moderately wasted and 8% severely wasted before the pandemic. So we did some assessment with Derek Heady using the DHS data sets and simulating the projected, the crisis and the projected increases in child wasting in India. So if you look at here you have, we'll focus on the moderate and severe wasting, and here we have the pre-COVID percentages that I mentioned, 12 and 8%, basically for moderate and severe acute malnutrition, respectively. And that corresponds to a very large number of children. For moderate, it's more than 14 million children, and for severe, it's more than 9 million children. Now, with the crisis, with an expected reduction in GNI of 10%, which seems to be quite a precise estimate, we would see an increase of 1.13% in moderate wasting and 1.78% in severe wasting. These two numbers here correspond to an additional 3,403,500 children, additional newly wasted children in India in 2020. So again, those numbers are daunting and really call for our attention to making sure that we can work harder to prevent the deterioration in child wasting in India. Finally, I just wanted to mention the call to action that 4 executive directors of UN institutions have signed. This was a publication in The Lancet in July 2020, which is really a call to action to protect nutrition during COVID. And I will go very briefly on the 5 recommendations that they provide, which cover recommendation for food systems, for social protection systems, as well as for health systems. Very briefly, the first one is to protect, promote, and support access to nutritious, safe, and affordable diets as part of the response to COVID-19. So this is a call for having food systems try to be more efficient at protecting diets during the time of COVID and related economic crisis. Maintain school meals. That has been mentioned by many. It is a very important activity. Action is a social protection intervention. And they propose to make sure to continue as much as possible through home delivery, take-home rations, cashier vouchers while schools are closed in so many countries. Third, prioritize nutrition through pregnancy and early childhood, protect breastfeeding and prevent marketing of infant formula. Those are actions, especially the pregnancy, the antenatal care and the early childhood nutrition support are important interventions that are delivered often through the health systems, and so keep those activities, interventions functioning during the crisis as much as possible. Reactivate and scale up services for the early detection and treatment of child wasting while expanding other nutrition services. This is, again, critically important for South Asia, for India, to make sure that those services in particular are giving a lot more attention than they seem to be given now. Scale up social protection programs to safeguard access to nutritious diet and essential services among the poorest households. Again, the emphasis on social protection systems, and we know there are lots of countries that have social protection programs that have either been refurbished or started, but we are fearing that demand greatly exceeds the supply. So in conclusion, here is the last message from this call to action from the UN. We must step forward together with sustained action and investments in nutrition today and deny the COVID-19 crisis and intergenerational legacy of hunger and malnutrition in children. So by protecting nutrition today, we will protect the future of nations. And we have to really remember that this is feasible and this has long-term impacts on the next generations. Thank you very much.
Thank you, Marie. That was quite a sobering talk to learn that we are going to be facing with this dire situation of wasting and mortality among children. We have to definitely think about what we can do and do everything in our scope to prevent children from facing these conditions. Now, let us hear from, and I would encourage everyone to continue to post your questions for Marie in the Q&A box, please. Marie has a wealth of knowledge and we should make use of her time here. Now let us hear from Dr. Jeff Leroy about COVID-19 implications on child growth. Will catch-up be possible? Dr. Leroy is a senior research fellow in IFPRI's Poverty, Health and Nutrition Division. He studies the impact of nutrition-sensitive agriculture and social protection programs on maternal and child nutrition. His evaluation studies use experimental designs combined with process evaluations and costing studies. Jeff currently works on the evaluation of a social protection program in Bangladesh designed to move birth outcomes and on the evaluation of a training and certification program aimed at improving the quality of milk sold by informal vendors in Nairobi. Jeff has a PhD in international nutrition from Cornell University. Pratima, could you please have this?
Hello, everybody, and thank you for attending this presentation. Thank you to the organizers for inviting me to present at this symposium. My presentation will also continue on the topic of COVID-19 and nutrition, but will take a bit of a longer perspective. As you've heard in Marie's presentation, the number of wasted children is expected to increase by almost 7 million in the first year of the COVID-19 pandemic. But this, unfortunately, is just a sliver of the COVID-19's nutritional harm. The burden of undernutrition is expected to increase, and this is a consequence of reduced household income, but also a consequence of supply chain disruptions, which limit access to foods rich in vitamins and minerals. An important question that many of us have wondered about is whether children will recover from when the crisis ends. And when we say recovery in the context of undernutrition in children, we quickly think about catch-up growth. What is catch-up growth? Well, it's the ability to reverse linear growth retardation. It's a topic that continues to intrigue the nutrition community, but important questions remain. One question is catch-up growth possible? And secondly, do children really benefit if they catch up in linear growth? The findings I will be presenting in my presentation were published earlier this year in the journal Advances in Nutrition. So if I have to leave out some details today, you can look them up in this open access article. Now, there are 4 criteria for catch-up growth. The first one is that you need an inhibiting condition, which leads to reductions in linear growth velocity. So when health is a problem, when diet is a problem, children do not grow at the expected velocity. In the second period, we need this inhibiting condition to disappear, and this subsequently leads to higher than normal velocity. An important comment here is that catch-up growth is about absolute height velocity, which means velocity expressed in centimeters and not in changes in height for HC scores. And more details, as I mentioned, can be found in the paper. Now, is catch-up growth really possible? What we did is we reviewed adoption studies. And why did we focus on adoption studies? Because they provide the most dramatic improvement in the child's environment. And when we say improvements in environment, we refer to the diet, to water, sanitation, hygiene, to care, to all of the factors we know contribute to linear growth retardation. So adoption studies can provide us the evidence of the upper bound for what is biologically possible. We focused in our review on studies that were conducted in children under 5 years of age, and we identified 11 studies with sufficient data for our analysis out of 70. And this is what we found, and I will slowly walk you through the graphs that show the results. On the x-axis, we have the child age in months, and the first dot on the left indicates at what age the children were adopted on average, and in this case, for this particular study, this was at 6 months of age. On the y-axis, we can see the growth deficit. This means how much shorter were the children as compared to the World Health Organization's growth standard. So these children at 6 months of age were between 4 and 5 centimeters shorter than they should have been. What we can see in this study is that by 48 months of age, or 4 years, children had a growth deficit of only about 1 centimeter. So these children did experience catch-up. The gap they had when they were adopted slowly disappeared. But there were also studies that we identified where no catch-up growth were found, and these are shown in orange on the graph. Children in this study were adopted also around -6 months of age. They had a growth deficit of -1 centimeter, and that this deficit only increased when they grew older. Now, when all of the studies on this one graph, we can quickly see that the majority of the lines are shown in green, which means that these children did experience catch-up growth. So in conclusion of the review, we find that catch-up growth is indeed possible, but there are some important comments we need to make. First of all, the improvement in conditions following adoption is extreme. As I've mentioned before, the diet improves, children are much healthier, sanitation, care, stimulation, all these things are taken care of. And the intensity of nutrition programs and policy is typically much lower than what children experience in adoption. Now, important also is what is the relevance of this finding for nutrition policy. First of all, the magnitude of the growth impact that programs and policies have, and that is based on the evidence in the literature, is only a fraction of that seen in adoption. We know that programs and policy can improve linear growth, but the magnitude, the size of that impact is smaller, much smaller than what we typically see in adoption. Very important also is, can children actually recover in other domains? And what we did in this review, we also looked at neurocognitive and brain development and at developmental epigenetics, and I will be sharing those results with you now. I'm going back here to the graph I showed on adoption, and I'm highlighting one particular line which comes from a study on orphans from Romania. These orphans were placed in foster care. And as you can see on this graph, these children did experience linear growth catch up. They improved growth. They had a gap when they were adopted of between -2 and -3 centimeters. And by the time the children were about 40 months of age, they had fully recovered in terms of linear growth. But when the researchers looked at these children's brain development, they found that in terms of gray matter, there was no catch-up growth. And when it came to white matter, there was some catch-up growth, but it was only partial. When children were participated in testing of cognitive testing, they also found that there was incomplete catch-up. So children did improve, but were not able to close the gap between children who had never been exposed to institutionalized care. So important here, these children did experience catch-up in linear growth, but did not experience full catch-up when it came to brain development and cognitive function. And then the other domain, as I said, we looked at is developmental epigenetics. This study was conducted by Rob Waterland and colleagues in the Gambia, and they conducted the study in subsistence farming communities. These communities experience very strong seasonality. And what the researchers found is that poor maternal nutrition around the time of conception, and in this area this was conception in the rainy season, increased the offspring's DNA methylation. So what they found was a clear association between the quality of the diet in the rainy season, which was much poorer, that's the hungry season, and DNA methylation. What does DNA methylation mean? DNA methylation modulates how genes are expressed, the potential for genes to be expressed. And what the authors showed is that these changes were permanent. So seasons left a permanent mark on how genes can be expressed in these children. In conclusion, undernourishment early in life leads to negative outcomes that are both profound and irreversible. The consequences for the COVID-19 mitigation efforts are clear. They should really focus on preventing child undernutrition now, rather than hoping that it can be treated later. We should make sure to keep essential maternal and child health and nutrition services running. This means we need to focus on antenatal care, safe delivery, immunization campaigns, preventive and curative healthcare, micronutrient supplementation as needed, counseling to support breast and complementary feeding, and so on. We should also really invest in programs that provide cash and food transfers or vouchers to allow households to make healthy choices as they have to cope with the economic recession. And then finally, we have to make sure to protect mothers and young children from unequal allocation of household resources, and also we have to also protect them from domestic violence and psychosocial stress. Thank you so much.
Thank you, Jeff, for that presentation. So you are making the point that the time to act is now, and we cannot really say, let's wait until the pandemic is done, let's take care of the pandemic and deal with nutrition later. We cannot afford to do that. Thank you for driving home that point. And now moving the settings from the global to the Indian context, I would like to invite Dr. Ranadip Chowdhary, who is a research scientist and assistant director in Society for Applied Studies, to speak about the case of early wasting in India, based on a research that he's currently conducting. Dr. Chowdhary is a medical doctor and also holds a PhD from Center for International Health University of Bergen, Norway. Currently, he is working as research scientist in Society for Applied Studies in New Delhi. He received Global Nutrition Early Career Scholar Award by the American Society for Nutrition in 2018. He's a member of the Indian Council for Medical Research Task Force on Anemia, Midterm Evaluation of POSHAN Abhiyan, and Conditional Cash Transfer. His primary research interest is to understand drivers of early infancy growth failure. Pratima, can I have Dr. Chowdhary's presentation, please?
I am Dr. Ranadip Chowdhary, working as Assistant Director and Research Scientist in Society for Applied Studies, New Delhi. I will give an overview on early life wasting in India in an intervention study context. In Society for Applied Studies, we are conducting an individual randomized control study, acronym of which is WINGS, Women and Infant Integrated Growth Study, which aims to measure the impact of an integrated package of interventions, that is health, nutrition, psychosocial care and support, and water, sanitation and hygiene, delivered during preconception, pregnancy and early childhood on birth weight, birth length, prematurity, small for gestational age, and length for age G-score and proportion stunted at 24 months of age. The study is being conducted in urban and peri-urban, low to mid socioeconomic neighborhoods in South Delhi. The study is an individually randomized factorial design. There are 4 groups in the study. Group 1, pre and periconception and pregnancy and early childhood intervention group. Then only pre and periconception intervention group, only pregnancy and early childhood intervention group, and routine care. Subsequently, in this presentation, I will present the data of wasting in early infancy from the 2 red highlighted group, that is pre and periconception and pregnancy and early childhood, and only pregnancy and early childhood intervention group. So the interventions in this study are in 4 domains: health, nutrition, psychosocial care, and WASH. And these were selected based on evidence of their impact on preterm birth, small for gestational age baby, birth weight and length, and linear growth at 24 months of age. And these interventions were finalized in consultation with the technical advisory group constituted for this study. I will primarily help focus on the interventions for the infants and infants in the first 6 months of life. So here in the first 6 months of life, from birth to 6 months of life, mothers are counseled on early initiation of breastfeeding and exclusive breastfeeding. Monthly growth monitoring is done for early identification of growth faltering, and the infants with inadequate weight gain, that is less than 15 centile as per WHO weight velocity per month, are referred to a physician consultation for morbidity assessment, and also to a lactational counselor for breastfeeding practices. Micronutrients supplementation are done for low birth weight and very low birth weight infants according to WHO guidelines, and age-specific child play and stimulation activities soon after birth, along with early identification of developmental deviations and their prompt management are the core components of the child care package. In terms of mothers are encouraged to visit the delivery facility according to follow-up schedule advised by the facilities, and mothers are provided locally prepared snacks and milk 6 days a week to meet the additional requirement during lactation. Counseling is being done using a module developed through adaptation of the WHO Thinking Healthy module, and in addition, iron, folic acid, calcium, vitamin D, and multiple micronutrient supplementation are being done to the mothers. So this slide shows the stratification of live births by gestation and age, gestation and size at birth in this study from the intervention group. So as we can see, from 1100 live births, 62.5% live births are term appropriate for age, gestational age, and not low birth weight. 11.7% live births are term small for gestational age and not low birth weight, and 12.7% live births are term, small for gestational age and low birth weight. And on the other hand, 5% of live births are preterm, appropriate for gestational age at not low birth weight. 4.5% live births are preterm, appropriate for gestational age and low birth weight. And 2.6% live births are preterm and small for gestational age babies. In this slide, I will show the mean weight for length G-score and proportion wasted in the first 6 months of life in the intervention group. So here monthly weights and lengths are being taken by the intervention delivery team, and WHO 2006 child growth standards are used even for the preterm infants. And as we see from this graph, the blue line shows the mean weight for length G-score and the shaded line shows at the confidence interval that there is initial upward weight for length G-score till say 2 months of age and thereafter a decline, and approximately 4 to 8% wasting prevalence have been shown in the first 6 months of life. This graph shows weight for length G-score by gestation and size at birth. The blue line and the red line shows for term AGA and preterm AGA infants respectively, and as we see that they are showing a plateau mean weight for length G-score pattern throughout first 6 months of life. And the red and the orange line shows term SGA and preterm SGA weight for length G-score graphs, and we see for them there is upward tilt till 2 to 3 months of age and thereafter a decline, but they are on different slopes. Here I am showing proportion wasted infants by gestation and size at birth, and the green bar shows term AGA infants, the red bar shows term SGA infants, yellow bar shows preterm AGA infants, and the blue bar shows preterm SGA infants. So prevalence of wasting is higher in SGA infants, both term and preterm, in the first 2 months of life. Term SGA infants have higher proportion of wasting compared to other categories from 2 months onwards. However, the wasting prevalence has decreased at 6 months compared to birth in all the categories. These are the attributable proportion of wasting at 6 months by gestation and size at birth. So approximately 55% wasting at 6 months is attributed by term SGA and preterm infants, which comprises of 38% of the total live births. On the other hand, term AGA infants, which constitute of 62% of total live births, attribute to 45% wasting at 6 months. So the prevalent and incidence cases of wasting at 6 months, as we see from this slide, that at 6 months 15% of wasting are prevalent cases, defined as wasted both at birth and at 6 months. 67% cases are incident wasting, that is no wasting at birth but wasted at 6 months, and 19% wasting at 6 months are unknown. That means that we didn't know their birth status because their weight for length G-score could not be calculated using WHO standard, as at birth their birth length were less than 45 centimeters. This slide shows the wasting rates in trial compared with a recent national level survey. The red line shows the recent national level survey, that is comprehensive national nutritional survey, and the green line shows the data from the intervention cohort. And as we see, from birth to 6 months of age, almost 50 to 70% higher wasting prevalence in the recently conducted national level survey compared to what we are finding in the intervention group cohort. So to conclude, mean weight for length G-score in the cohort or intervention cohort show an upward trend in first 2 months of life, followed by a decline. For term and preterm AGA babies, this mean weight for length G-score follow a plateau throughout the first 6 months of life. But for term and preterm SGA babies, they had initial upward and followed by decline, but on a different slope. Wasting rate varies between 4 to 8% during first half of infancy in this intervention cohort. 55% of wasting at 6 months attributed by term SGA and preterm infants. Almost 2/3 of wasting at 6 months are incident cases, and wasting rates in the intervention cohort approximately 70% less compared to an average from a national survey. Thank you.
Thank you, Ranadip. That was a great study, and it shows how a package of interventions can play a protective role. And what I realized is most of the interventions that you have listed are indeed part of our national systems. So at a later point, it will be great to hear if the intervention packages were delivered through the government system, or if you had separate intervention team that was delivering that. Now, I would like to invite Dr. HPS Sachdev to give his remarks on addressing wasting in India during COVID-19 and beyond. Professor Sachdev is Senior Consultant in Pediatrics and Clinical Epidemiology at Sitaram, Bharti Institute of Science and Research, New Delhi. He's an adjunct professor at St. John's Research Institute, Bangalore, and visiting professor MRC Epidemiology Research Center, Southampton. He has been honored with fellowships from the Royal College of Pediatrics and Child Health in London, National Academy of Medical Sciences, and Indian Academy of Pediatrics. He's a National Research Awards recipient, including from the Indian Council of Medical Research. Over to you, Dr. Sachdev.
First of all, I would like to thank the organizing team for giving me this opportunity to speak. Let me begin with a philosophical statement that it is very challenging, lonely, and frequently fatal to swim against a very powerful tide. But the philosophy which I adhere to is, if it doesn't kill you, it makes you stronger and wiser, and it's better to speak out what you feel is true or in your heart. Since I'm frequently misunderstood when I talk about these things, it would be important for me to clarify right up front that quality food is indispensable for leading a healthy and a productive life, and it is especially important for children. But often we forget the age-old wisdom or saying that one man's meat can be another man's poison, and excess of everything is bad. That was a great model which Marie presented, and must have been done by much more experienced experts and all. But I am a practicing pediatrician or a clinician, and after this, I mean no disrespect to the model. There are several of them floating on the prophecies or the predictions, as you want to call, of the adverse effects that will occur. I'm reminded of a saying by a famous statistician, George Box: all models are wrong, but some models are useful. I hope this model is useful. The issues that I feel that this model is probably a little overstatement to my mind, I pray that I'm totally right about this, are I would have liked to see perhaps the uncertainty of these models rather than just the mean of the millions or 13.8% or whatever the figure was as confidence intervals. And one of the issues I've had with this, which I have tried to discuss, is that we always assume that the exposure remains constant throughout the period of the 6 months or 12 months, and that everything which is happening will be remaining the constant. And the variations that do occur or the changes that occur by itself are not accounted for. And I am always perplexed by this list model and the other model in which they are using indirect effects to calculate how indirect associations, which is a different field of science. The economists love it, the agriculturists, but I, being a clinician and would like to see a randomized trial. And we have recently published data at this moment, not once, twice, about that the mortality is much less. And I presume we are talking about uncomplicated SAM, that is non-infected severe acute malnutrition as it's called here. And the mortality in the 1 or 2 months, if it's a acute, if it's a severe, and it's a malnutrition, it's emergency, the child should die in 1 month. And right there in the tribal areas of Odisha, Jharkhand, or in Meerut, the mortality was less than 2% in the first 1 month, or 1% of the case fatality. And if you extend it, it would be less than 4% is what the figure we have got. So if you input this direct mortality estimates, I don't know what you will get. The other thing is that this model is probably ignoring, I don't know the details, it obviously not told, the biological adaptation in the children and everyone which occurs with decrease in the dietaries, like the absorption, the tissue metabolism decreases, the mobility decreases, and more important is you are encaptivated in a space, the physical activity is declining, and in fact in some urban areas there is a concern that they are increasing these going towards obesity, but that's a different sort of category, but we do have to think of them. Now I am sort of seeking support in this. The epidemic is ongoing for 6 odd months. And we have not seen as many deaths as far as we can make out from the doomsday. The supply chain is acting. And I mean, this was one of the priority, the first priority that the government did was to have the distribution of the foods going on to all of this. And apart from that, our society is quite philanthropic and people were giving their own savings and distributing the food to all others. So we have not seen this much disruption of the food chain. In fact, our agricultural GDP grew by 3.4% while everything was going down. So this could be that it has not gone into the hinterland. It will be going now. We don't know the epidemic, but I am not as pessimistic as these models suggest, and I pray to God that I am right. But I would tend to agree totally with Mary. She did not only focus on food. There were 3 other pillars that she had suggested, and this was important. Now, coming to the other thing, we always are talking about wasting. Now, what actually does this metric indicate? To my mind, I don't have the time to detail it. In the way it was constructed, the WHO references never, ever quantified the food intake. They took the cream of the societies, 5 to 10%, whose mothers had no intergenerational constraint. Their water supply, sanitation was good, education, breastfeeding, all the health practices were there. So to my mind, I think wasting has been, the term is a magnifying a physiology into a pathology. I don't deny some of these are a proportion which varies with time and with place, are likely to have effect of poverty through food also, but I would prefer to call them thinness or thinner children who do require a diagnosis maybe at the community level and to see. No doubt they are more likely to die, but that's a biological effect. Even if there's a hospitalized, you take any children, any children also, we have published on that, the ones who are undersized are more likely to die. So I would rather say that we always severe acute wasting is food is incorrect to my mind. So the undersized Indian children is not that much with an intergenerational constraint. It has an intergenerational constraint. It's not that much nutrient starved as it's hungry for overall development, including poverty and the other things. Now turning a little bit poetic, I'm reminded of a sher which is "Aur bhi gum hai zamane mein," and translating for the international audience, there are many other sorrows in the world. The government has finite resources. What does the government focus on? Making more tests for the COVIDs available, or taking care of the ones who are crucially sick, supplying oxygen to them, or having health access for them? Vaccinations, there is a hue and cry, the vaccination is going down, so many deaths will occur because of that, and so many other things, the floods coming, what on and what should not be there. So government has finite resources, and we do care about our children and our population. The politicians, it's the politicians' business to show that they care, otherwise they will be thrown out. And so all I would say is that having too many panic buttons, or one part like the vaccination vying with the nutrition, or the third one like the COVID test and testing, doesn't help anyone. It sort of breaks away our rationality, and let the government focus on them with the finite resources and decide what are its priorities. Undoubtedly, and as you have said, and what Jeff's presentation also showed, is that it's not only about food, it's all about developmental, overall developmental or living conditions improvement, and no one is arguing. So the basic dictum in COVID is to try to maintain what was going on, and it is definitely an issue of equity. The underprivileged are likely to be much more affected, so one would try to focus on that. But I have a couple of issues with Jeff. He chose absolute height, while we have shown in a paper, yes, while the improvement of the height for age Z-scores occurs, which is different from what the subject was on wasting. He's talking about length, which is an entirely different field from that. But if the height absolute gap increased, but the height for age Z-scores decreased, the jury is still out. One cannot say this is better or not. So one decides to pick up one side, it will be better, while the other side, it will not be better. Now, he also suggested or said very clearly that it's not possible, or there are likely to be scars, or in the long term in the nutrition. We have just in June, July recently published a discussion paper from our 50 years ongoing cohort of New Delhi birth cohort, which is online and easily accessible. And there we see that the effect on the practical measures in life, which would be the income, the wealth, the education attained, and the occupation, is very little. For one standard deviation, it hardly comes to 0.57. And exploring the data from one that had growth failure, we could not really see that this much scarring or this much effects which are gone there. But I don't deny it, that children are more vulnerable, and I am in total agreement with what he said. There are a host of things that should be done to improve this, rather than just focusing on food only. And it's the prevention, whatever you want to call it. And we are really trying to improve the birth size, and the plasticity of length is pretty low once you are given an intergenerational. So the time is sort of, I've been warned about that, but I wanted to comment on Chowdhary. So really, I will end out there if you have more point, but I would say that food is only a part of the overall development. It should be taken care. And what is more important is we were facing, I don't know how much COVID will upset it, the epidemic of escalating overnutrition, and the data we have published 15 years ago, which would have gone away right now much higher, shows that those who were wasted children from 5 to 19 years, 9%, I repeat, 9% of them, or 1 in 10 roughly, had features of metabolic markers of overnutrition, cardiometabolic overnutrition. So we need to be careful. And I'm not sure what was the idea of Ranadip to compare CNNS, not then for that. I would have wanted to see the control data comparison in that, and I'm not sure how the code was broken. I would, Rasmi, not agree with your interpretation that the wasting is lower because of that. Since we have a direct arm, which is a control arm, we would like to see whether that made an effect or not. And rather, I would be worried if they are given more food, have the mothers develop gestational diabetes. So with that, I'd like to end. Yes, overall development, poverty, address inequity. Thanks. Sorry for exceeding slightly.
Thank you so much for those wonderful remarks, Dr. Sachdev. I have heard that there are minor disagreements around the magnitude and the extent of scarring, but what I take away from you is overall you're agreeing that the package of interventions, the need to focus on child nutrition and what are those needs, they go beyond food and they include all the elements, and we need to focus on them to ensure that the children grow well and thrive. So just wanted to open it to the audience, just to say that we are on dot at 6:30, and our panelists have kindly agreed to stay on for a few more minutes to respond to your questions. And I know Marie has to leave in just about 5 minutes. So first I'll direct the questions that are in the Q&A box to Marie, that are directed at Marie, and then I'll come back to Jeff. And there are some overarching comments where I would request Dr. Sachdev to chip in as well. Marie, the question 2 is from Sam Scott. He asked what % of the predicted increase in wasting was attributable to crippled health system and what % was attributable to decline in GNI per capita. And the second question is from Sapna Nair, and she asks, do you also take into account the children who will be born this year, who will be born with low birth weight? And finally, Shruti Syriac says, very sobering talks, Marie and Jeff. What should be the top priority for our nutrition community in India in addressing child wasting and stunting? Marie, were there any particular health system interventions that had a greater impact in the list models? Over to you, Marie.
Okay, okay. In terms of the model, and just to say, also to respond to Dr. Sachdev's, some of Dr. Sachdev's very rich comments, you know, I totally agree that models are as good as the assumptions underlying them, and that there are lots of imprecisions and assumptions that we may or may not be confident with. Just so the main point for me is that this was meant to be an exercise for documenting or for giving some background to a call to action. So it's not that we expect that there will be exactly 6.7 million additional deaths. It is that we wanted to have a model that people that know the list model very well and have worked with it, joined forces with a group of other researchers, and that those estimates really are based on as good as it gets in terms of prediction models and the enrichment of the list model that usually predicts only changes due to health system coverage. We added the economic crisis, which we expect will also increase the problem of wasting. So all of that bundled into a model that, as we know, these models are a big machinery, and they just spit out some numbers. There are confidence intervals in the Lancet paper that was published, but the main point for me is that we shouldn't expect that there will be exactly the number that is there. This is really not the point. The point was to try to raise awareness of the issue, make sure that countries were very aware that there is a big risk of additional wasting, and wasting is a very important cause of mortality. And so the type of pandemic and economic crisis that we have is really likely to have a large impact globally on wasting. Now, whether the numbers are accurate and all of that, I think it's not exactly the purpose of the exercise. The purpose was really to raise the issue and to advocate for action, immediate action. 1 month of not having SAM and NAM programs can have enormous damage. 1 month of not having vitamin A supplementation. And so, you know, month by month, if you think of the potential damage globally of what could happen. And this was also a call for health services to try to reopen, try to prioritize the interventions also that they would keep functioning. So I totally take your point. I'm not an economist, I'm a nutritionist, and I know nutritionists are not so comfortable with these kinds of modeling exercises. But for me, the main point is not the actual exact number, is that the problem is really big, and this is to emphasize that. And the call to action that the UN institutions wanted to make, and the priority actions that they recommend. So in terms of the question, I don't have the exact numbers here for what the percentage of wasting and mortality were due to reduction in coverage versus to the economic crisis. As a first point, the reduction in coverage was absolutely impossible to get from countries. We had UNICEF try very hard to get estimates of what was the reduction in coverage of different types of interventions in all of the countries in the world, and it proved to be impossible. To this day, we still don't have that information. It changes rapidly. So we had very poor estimates of the change in coverage. So we just estimated with a 25% reduction in coverage of all of the interventions that were modeled in the LIST program. So that's an overestimate in some places and an underestimate in other places, and it changes every month, as I said. So that's one source of variability and lack of precision in the estimates as well. We just cannot get that figure and that information from the countries, understandably. But when we looked at the relationship between income and wasting, on the other hand, we found some elasticities, a coefficient that if you have a reduction in GNI of 10% at the country level, this results in a 14% increase in the risk of wasting, moderate and severe wasting. And if you isolate severe wasting, it's related to an increase of 22% in severe wasting. So those coefficients are large, again, just from the crisis. And I think, as I mentioned in the talk, we all realize that the impacts from the economic crisis are likely to be much more detrimental over time. We cannot expect that the countries will recover next year, even if a vaccine comes. And so this increase in wasting, or this increased risk of wasting and child mortality, will continue in the year or years to come as well, because of the tremendous impact on food security. In terms of priority, obviously maintaining all of the preventive services that health services are delivering is critically important. We need the essential nutrition and health actions to continue to function, to prevent malnutrition and to prevent illness. We also need to have the systems to care, the treatment of severe acute malnutrition. Those CMAM programs, or those programs that are operating at the facility level, really have to be strengthened, not just continue to function, but they should be strengthened. And then if you go back, also the screening has to be effective. We need to screen more, because we know it could happen that we have more children suffering from mild wasting. We should screen for mild wasting and then take those children into care, because they are the ones that are most likely to become moderately and severely wasted. So those programs are really important. And then the management of the severely acutely malnourished children is critically important to prevent mortality. They have to recover. And so I think those, from my experience in West Africa mostly, the CMAM programs are not strong. They're not operating as they should. There's a lot of children who are detected, identified as suffering from severe acute malnutrition that actually never make it to the CMAM programs, never get entered in the system. And so we need to strengthen those, and it's a difficult time to do that, but countries have to be ready for an increase in the number of cases and an increase in incidence, and they need more of the treatment as well, the RUTF, and the attention to those children. I will leave it at that. Long answers.
Thank you, Marie. Thanks a lot. And thank you for joining us. I know you have to go, so thank you again for coming and sharing your wisdom with us. Thank you. And please stay on if you can. I just thought you had. Now, I know Jeff has already responded to a question online. And so I have a question for Dr. Sachdev. So the question is for Dr. Sachdev. It's a Jagriti Chandra asks, in India, we are yet to open Anganwadis, although it has been 6 months. What would you like to say about that? Isn't that a cause of concern?
Yeah, it's a cause of concern from the sense that the children who came to the Anganwadis were not, but the government has been proactive from that sense, and there have been attempts, or at least on paper, I don't know anything about the ground situation, that the take-home rations or the equivalent has to be sent to their homes. And I understand it is occurring in places, but one can never be certain about the more underprivileged who are going to get away from this thing, and that's the best that they can operationalize. So the government is aware, they are trying to take action. I don't know how successful it is on the ground.
And the next question can be taken by either any of the panelists. And the government of India has introduced schemes to address food security during the lockdown. Does this help in addressing the risk to child wasting as well? Jeff, would you like to take that?
Yeah, I'm not sure I'm the best person because I'm not an expert on nutrition in India, but an important cause of wasting is indeed that food security, food insecurity at the household level. This is what we see in many regions and countries suffering from excessive child wasting, that it's very seasonal, and it's related to the harvest season, which is an indication that it's related to food availability at the household level. So I would expect that in very general terms, that programs that try to address the issue of food insecurity would have a protective effect on child wasting. But again, I do not know the context in India well enough to comment on the specifics of this.
So let me try to respond to that. As I said in my remarks, food is only a part of this. If you starve a person or make the person hungry over time, obviously the person is likely to become thin, but in most scenarios, one has to try to see that the child is not infected. So if the food which has been given in the family is deprived, it would certainly be helpful for preventing this, and that's what it is. You cannot predict what will be this across the same, one size will not fit all the regions of the country and at all times of how the epidemic is panning out. I forgot to mention one thing, because people are not moving around. Otherwise, the other infections which lead to such things, but vaccinations could upset it, are less. So because people are not coming in contact with each other. So yes, that was one of the pillars which one has to take care. So the food is a welcome step to ensure that people are getting it.
Thank you, Dr. Sachdev. And in the interest of time, we are already more than 15 minutes. I have one question. I think that it's quite important, and any of you could take it on. The question is from Megha. It says, from a development biology perspective, we understand there are windows for events to take place during fetal and early childhood development. This is in terms of immunity, cognitive function. How do policymakers think about these biological phenomena in the backdrop of wasting? The data are for children in first 1,000 days, which is a long time in development, and it's possible depending on the time of wasting. A particular developmental insult will develop. Is it possible to overlap wasting data over developmental windows and interventions? That's a great question.
Shall I take this question, sir?
Yes, Ranadip, please go ahead.
Yeah, so it's a very important question. One thing we need to understand about the developmental biology, 1,000 days, and now the recent concept of 1,000 days plus, that is starting intervention from preconception. So this is a mother-infant diet. So any insult to mother in early pregnancy, or when the mother is planning, woman is planning to have become pregnant, that means in the preconception, or if we say the pre and periconception phase, in the first 3 months and even that period. So any insult to mother and woman at that time point in terms of nutrition, in terms of infection, in terms of some environmental function, that may have an impact on mother and also the fetus. An impact of that fetus during the fetal life and subsequently in the first 2 years of life may have an implication. The data I have shown, though this is a data from an intervention trial and also for the intervention cohort, where all the possible effective interventions are being promoted, still we can see that those who were small for gestational age, that means probably they had fetal growth restriction during fetal period, they have higher, more or increased risks of wasting even in the intervention arm or intervention cohort in the first 6 months of life compared to those who were not. So this is the window we also need to think care about. Government is planning in that, but the problem what we are facing, and according to me, Dr. Sachdev can interpret more better, that in India, the pregnancy are being reported either in the early second trimester and also sometime in the late second trimester, mid second trimester. That means you already lost almost first 14 to 16 weeks. So we are left with only 20 weeks or 22 weeks. And what we need to do? We need to first correct if there is deficiency, number one, and number two, there are some additional requirements that we need to rectify. And this 22 weeks or 24 weeks, according to me, is a very short time period to change all the aspects of mother and the infant and subsequently the development of infants. So early identification of pregnancy, and if possible, though there is no as such available evidence to show the proper effect of preconception care on subsequent infant development, that could be a potential area that policymakers can think about, but definitely we need more evidence to think about the preconception care. Thank you.
Thank you, Ranadip. May I ask Jeff to take a couple of minutes and give his thoughts on that? And then I'll ask Dr. Sachdev to take a couple of minutes, and then we can close the session.
So I think the general principle is clearly that plasticity is higher at younger ages and it goes down. But I think it's important to also pay attention to the fact that there are still critical windows after the first 1,000 days. The first 1,000 days has helped us enormously to bring nutrition on the agenda. But there is nothing that changes in the biology or in the developmental process at 2 years of age. I sometimes jokingly say that I send my children to school, they're 10 and 13 years old, because I believe there is still some developmental potential in those children to learn. So we have to pay very close attention to pre-pregnancy, pregnancy, the early years of life, but we have to continue to pay attention as children grow up and go to school. Their nutrition is important, their environment is important in all sorts of domains. So I just wanted to add that in there. Thank you.
So if I talk of evidence, to my mind, yes, if you think of the first 1,000 days, that's the time when the fetus and the child are young and are vulnerable. And I talk with a sense of evidence from our New Delhi birth cohort. The effect size is pretty small. I mean, it makes sense to act at a vulnerable period of the life and do it. Yes, they are vulnerable. But if you are asking specifically for wasting, as to how it goes within this 1,000 days. I'm sorry, we could not find anything, and I didn't get time to show my slides and what has not come out in this presentation, that you leave the children alone in what they are, and that were whatever 2 studies was, they get automatically treated. And at the end of 4 weeks or 8 weeks after the intervention has ceased in one of the multicentric trials, and later on in what you did after 8 weeks, the recovery rates are equally all right. So when you make a child fatter, as a population, we are roughly 1 standard deviation more thin than the WHO reference, and we are healthy and going back. This paper has been published as a preprint from CNNS. How can we know what we are causing wasting in that individual child has not transgressed the boundary of overnutrition for that child and following the trajectory of developing non-communicable diseases? In short, I am in 100% agreement with what Jeff said. Yes, it's a vulnerable period. There's more plasticity. Actually, there is more movement, and I think that's a prediction of how, maybe because of the genes or the life conditions, the trajectory the child is going to follow. But other periods are equally important, and insult at any time period, and in rapid growth, for example, in adolescent, is going to be there. So 1,000 days is not meant to say that the other periods of life are not important. Thanks.
Thank you, Dr. Sachdev. We are, I recognize we are well over time, but thank you all to the panelists for staying on. And thank you so much to all the attendees for continuing to stay on and listening to these deliberations. I think one key takeaway, there are a couple of key takeaways from this session, and which resonate from what we have heard in the morning as well, that we have to screen for SAM, and we have to have put in place management for SAM children, given particularly in the COVID situation. At the same time, we have to continue to focus on prevention as well, so that we don't have more children falling into the SAM category. And we have the POSHAN Ma coming up, and the focus of the POSHAN Ma is already on screening and management of SAM. So that's taken care of. So we also have to come back and refocus our energy on prevention as well. With that, I'll bring the session to a close. Thank you so much. And please join us tomorrow morning for our next plenary session, which is focused on COVID-19. Thank you.
Thank you. Thank you.
Thank you.
Thank you, Rasmi. Thank you, Professor Sachdev, Jeff, and Ranadip.
Thank you.
I think Marie has left, so thanks, team.
Thank you.
Thank you all.